Good afternoon, everyone. Welcome to the first Young Physician Forum and the college lecture for 2023. As the new president of Sri Lanka College of Physicians, I would like to welcome you all who are here physically as well as who have joined the through the Zoom platform. It will be great to have everybody here. Special thanks goes to Dr. Tushara Matthias for organizing this, spending a lot of time. And thank you very much for all the presenters agreeing to do this for us, college. So I'll move into the first lecture of the Young Physician Forum. It is by Dr. Umesha Vijayanayaka, Senior Registrar in Endocrinology, National Hospital, Sri Lanka. The topic is targeting metabesity. Over to you, Umesha.
So without further ado, let me move on to my presentation for the day, which is targeting metabesity. So to set the stage for the discussion, let me present you a case history. So she's Mrs. L. She's a 32-year-old lady. And for the longest time known, she has always been overweight. She says that her family members had always been big as well. And she lives in Colombo suburbs now. And being an IT professional, she works for very long hours in a seated position and says that she doesn't have any time for exercise. Over time, she has noticed that her weight had been gradually creeping up. And now she's a mother of 2 kids. And during her last pregnancy, she was diagnosed with gestational diabetes mellitus. She's worried and frustrated because she has tried all sorts of diets to see that even though she loses few kilograms initially, the weight will regain. And at some point, it will even exceed her original weight. So now she's 1.6 meters tall, she weighs 105 kilograms, and she has a BMI of 41. So this is a very common story that we see in this day and age. So with that in mind, let's move on to explore this interesting concept of metabesity. So over the next 25 minutes or so, I will be giving an introduction to metabesity, followed by a discussion on its etiology, clinical indicators, and treatment options. So all of you here in this audience might be quite familiar with the terms obesity as well as metabolic syndrome, and might be wondering what exactly is metabesity. Well, nothing complex. It describes a spectrum of interconnected metabolic diseases ranging from obesity, metabolic syndrome, diabetes, cardiovascular disease, dyslipidemia, cancer, neurodegenerative disorders, and accelerated aging. The commonality of all these conditions is that they share same metabolic and inflammatory roots. If you really see a real-world patient, most of the time, the conditions that I described previously occur in combination. And in fact, it has caused a major health and economic impact worldwide. So if we can address these very metabolic and inflammatory roots, I think it would be a cost-effective option in targeting these chronic diseases, or in other words, metabesity. So which would be the focus of my presentation today. So looking into this very complex relationship between obesity and metabesity, if I'm to summarize this, metabesity is a result of inflammatory and oxidative damage, as I mentioned. And this, in turn, is caused by insulin resistance, which is a result of obesity and visceral adiposity. So at a global level, obesity is a major risk factor for a number of chronic diseases, or in other words, metabesity. And how big of a problem it is. If we look into the global landscape, as you can see, the countries highlighted in orange color have the highest obesity prevalence. And it is estimated that it was found that in 2016, the global prevalence of obesity was 13%. And in fact, it was expected to rise to 15% in 2020. And at a time where the world is still battling the aftermath of COVID-19 pandemic, if you look into the mortality data of COVID-19, it is nearly 6.6 million as per data of December 2022. And if we keep COVID-19 aside for a moment and focus on obesity, though it is not a direct risk factor or cause of mortality, the resultant metabesity has made it one of the leading risk factors for early death. Globally, 4.7 million people have died prematurely as a result of obesity in 2017 alone. So in summary, for a single year, the mortality rates are more or less in par with COVID-19 mortality. And to say obesity was a risk factor for severe COVID infection. So that's why halting the rise of obesity was one of WHO's global targets in NCD prevention for 2025. And where are we now? In fact, we are catastrophically off track to meet our targets, as obesity rates are rising at an alarming rate worldwide, and it is expected that by 2030, 1 in 5 of women and 1 in 7 men will be living with obesity, equating to over 1 billion people affected with obesity worldwide, for a cumulative prevalence of 18%. And to make the matters worse, childhood obesity is often carried into adulthood. And as you can see, global prevalence of childhood obesity is rising in similar rates. And to put that into context, by 2030, it is expected that 1 in 8 of all children and adolescents will be living with obesity. So one might have to accept metabesity and its consequences in generations to come. Sri Lankan data also demonstrates a similar rising trend in obesity prevalence. And in comparison, now a predominantly younger age group is affected. So obesity is a growing epidemic worldwide. And World Health Organization defines this condition as an abnormal or excessive fat accumulation which presents a risk to health. And if we want to target metabesity by targeting obesity, which is its root cause, I think we should have a sound understanding about the etiology as well as pathogenesis of the condition. So historically, it was believed to be a mismatch between energy intake and expenditure. However, later on, as evidence emerged, we identified that it is not that simple and in fact complex and multifactorial. Biological, environmental, and psychosocial factors has a role to play. And in the bottom line, if you want to target obesity, we might have to target each of these factors appropriately. And zooming into these biological factors, epigenetics, genetics, and gut microbiome play a major role. And in environmental and psychosocial spheres, factors like geographic variation, natural resources, policy decisions, economics, cultural characteristics, body size perceptions in the society, as well as cuisines may have a role in influencing. So moving on to the environmental sphere, if we look into the obesogenic environments, the urbanization and technology and the economic transition contributes to development of obesity in today's world. And urbanization and technology, by decreasing the energy expenditure and decreasing the quality of the diet that we are consuming, contribute to obesity. And looking into the economic transition and its impact on obesity, as you can see, when wealth increases, society move on from a stage of undernutrition to a stage of balanced feeding, to a stage of overfeeding, which is associated with westernized diets and sedentary lifestyles. So then comes a dipping point or a recovery stage where people understand the importance of a healthy lifestyle and move on to a much healthier lifestyle and an active lifestyle. So seems like an ideal world. However, one must note that this does not refer to a particular historical period, and different subpopulations within the country can demonstrate different stages, and different parts of the world can demonstrate different stages. And further, looking into the impact of socioeconomic status and obesity, as you can see, in stage 1, the obesity prevalence is much lower, and females with a higher socioeconomic status is predominantly affected. But then you get stage 2, where the obesity prevalence increases, and there's a narrowing of the gap of obesity rates in men and women. And then comes this very important stage 3, where obesity prevalence in men further rises, and in comparison to stage 2, here, predominantly lower socioeconomic class is affected with obesity. And then comes the stage 4, where we see a declining prevalence. And as a population, if you want to target this condition, we should focus on transitioning into this stage, which of course is not an easy task. And how does this environmental sphere intersect with the biological sphere? And that is through epigenetics. That is where genetically identical individuals demonstrate different clinical phenotypes depending on the environmental cues that they receive. And when discussing about the environmental cues, I think the role early nutrition plays here should not be forgotten. In fact, if you look into this relationship, undernutrition in the fetal life, as well as excessive feeding in the perinatal period, increases the risk of adulthood obesity. And breastfeeding was found to be protective. And if we want to change the direction of this trajectory, of course, we might have to focus on these early nutritional practices. And this takes us to this very important concept of transgenerational imprinting of metabolic prospects. What this describes is insults in the fetal life in the form of obesity in the mother, diabetes, gestational weight gain, and diet will result in a neonate with excess adiposity, birth weight, and metabolic risk biomarkers. And that, along with maladaptive feeding practices in the infant period, will result in a child with excess adiposity and metabolic risk biomarkers. And the end result would be an adult with obesity and resultant metabesity. So if we are to stop this transgenerational spread, we might have to plan our interventions very early in the preconceptional counseling. And as we're discussing about the biological sphere, we should not forget gut microbiome. The human metagenome comprises of the human genome as well as microbiota, which colonizes in humans. And of that, the largest collection is found in the gut. And studies have demonstrated that the bacterial composition of this gut has a direct influence in obesity. And in fact, in obese individuals, there's a lower bacterial diversity. And if we can change this gut microbiome towards a more favorable and a more diverse manner, that can cause a significant impact on reducing obesity prevalence. And if we look further into this association, alteration of gut microbiome is a result of the dietary practices that we have now, as well as early use of antibiotics. This in turn will cause changes in bile acid metabolism in our gut, as well as short-chain fatty acid production by gut microbiomes and production of metabolic endotoxins. And these short-chain fatty acids in turn will modulate our gut hormones, which will affect our satiety. And bile acids and metabolic endotoxins through various other mediators would disrupt the lipid and glucose homeostasis as well as induce a chronic inflammation. So the end result would be obesity and the resultant metabesity. And the point that I want to highlight here is, in fact, the newer molecules like GLP-1 receptor agonists and metabolic and bariatric surgery has a role of modulating this gut microbiome in a favorable way, which is, of course, very useful in obesity care. And then we can move on to understand this very important concept of understanding the physiological regulation of energy balance, or the gut-brain axis. So So in summary, brain has a vital role to play here, and namely the hypothalamus and the midbrain. And it receives its peripheral signals from the stomach and small intestine, pancreas, and adipose tissues. And the meal-related afferent signals are mainly coming from the stomach and the small intestine, where ghrelin stimulates your appetite, and polypeptide Y, GLP, and CCK would inhibit your appetite. The long-term afferent signals, in the other hand, is coming from pancreas in the form of insulin and adipose tissues from the form of leptin, which in turn will inhibit your appetite. And the end result would be brain sending different outputs to modulate our appetite and energy expenditure. And also certain factors like age, gender, sleep, and rewarding stimuli in the childhood may have an effect in modulating these responses. And what I want to highlight here is that most of these regulatory pathways operate at a subcortical level. So this is where, when lifestyle interventions fail, one might have to look for alternative treatment options in the form of medical management or metabolic and bariatric surgery, which in turn will make some effects on these regulatory pathways. And also a word of mention on these genetic causes of obesity. Of course, it is twofold, monogenic and syndromic. However, these causes are very rare, and it's highly unlikely that these conditions are contributing to the rising prevalence of obesity that we see in today's time. So as you can see, the pathophysiology of obesity, which is the driving factor of metabesity, is rather complex and multifactorial. Therefore, our approach towards this condition should be multifaceted. And if we are to approach obesity, I think we should have a sound understanding about obesity measurements, and this is where obesity indicators come into play. And for the longest time, body mass index was used to measure obesity. But then again, there are loads of other indicators we can use for obesity measurement, starting from waist circumference to more advanced techniques like DEXA and MRI scans, which measure our visceral adiposity. Of course, what do we expect from obesity indicator? It should give a clear understanding about the downward metabesity risk. So when studies looking into the correlation between the obesity indicators and metabesity risk, factors like waist-hip ratio, waist circumference, and waist-to-height ratio had a better correlation in comparison to body mass index. And another criticism of body mass index would be that the inter-ethnic variation with regard to metabesity risk it is demonstrating. If you look into the relationship of BMI and metabesity risk in Asian population, which is highlighted in blue color, are at a higher risk of metabesity at a fairly lower BMI. So that is why Asian-specific cutoffs for BMI has come into practice, and this Asian-specific cutoffs might be useful in deciding our treatment options in these specific subpopulations. And also, similar cutoff values are applicable for waist circumference as well, depending on the metabesity risk. And with BMI being an imperfect index of obesity and measures like waist circumference having a better correlation, we can move on to the discussion of visceral adiposity as a measure of obesity. To consolidate this idea, I will use another case history, in fact, a comparison of two cases. The first one is a 37-year-old female, while the second patient is a 36-year-old female. And both were referred to us for further management of obesity. The first one had a BMI of 42, while the second patient had a BMI of 43. First one was pre-diabetic. She was not a hypertensive patient. She had borderline elevated cholesterol levels, and there was no evidence of fatty liver. But in comparison, the second patient was a diabetic. She was treated for hypertension, dyslipidemia, and she had grade 2 fatty liver. So in summary, the first patient for a BMI of 42 had less florid metabolic complications, but the second patient for a more or less similar BMI had florid metabolic complications or in other words, metabesity. So what made the difference here? When we looked into the body composition analysis of both these patients, both of them had more or less similar total body fat percentages. But as you can see, the second patient was having a rather higher visceral adiposity index. So that is why the world is now moving into body fat percentage as a marker of obesity, where more than 25% of total body fat and more than 33% of total body fat in females and 25% in males is used to define obesity. So as we can see, the importance of visceral adiposity in downstream metabesity risk, I think we can move on to discuss this other very important concept of normal weight obesity. In this very famous paper, which was published in Lancet in 2004, to your right, you can see an Indian physician, and to your left, you can see a physician from UK. And both of them had exactly similar BMI, which is normal according to the global cutoffs. But when we looked into the body fat percentages, the Indian physician had a much higher body fat percentage in comparison to the Caucasian one. So this led to this new phenotype of normal weight obesity, where they are having a seemingly normal BMI, but a fairly high body fat percentage. And I think as physicians, it is very important that we identify this particular group of patients because they are also at a need of necessary lifestyle interventions as well as relevant metabolic screening because of their seemingly normal BMI, they can be easily missed and they will go on to develop all these downstream complications. So I think measurement of obesity has now moved beyond the numbers of BMI. And then looking into this very important relationship between obesity and metabesity, one cannot forget the important link of metabolic syndrome. It is a constellation of reversible major risk factors for metabesity. And the diagnostic criteria has evolved over time, but the fact that I want to highlight is the importance given for central obesity, or in other words, waist circumference, which is a surrogate marker of visceral adiposity in this criteria, making it an absolute requirement. And also here they have appreciated the ethnic specific variations in these obesity indicators. So if we are to target metabesity as a disease, rather than treating all these downstream individual conditions, if we can address the root cause of this, which is obesity, I think that will save us a lot of trouble. So treatment of obesity focuses on achieving a clinically meaningful weight loss, which in fact is 5 to 10% weight loss from their initial weight. And how do we do this? That is through lifestyle modifications, pharmacotherapy, and metabolic and bariatric surgery. The conventional guidelines still recommend obesity treatments depending on the BMI cutoffs. And the degree of BMI reduction of weight vary depending on the treatment modality that you are choosing. And depending on the degree of weight loss that you are targeting, you can pick and choose your treatment options. And as BMI being an imperfect index of obesity and more importance given to visceral adiposity as a marker and concepts like normal weight obesity coming into practice, I think it's high time that we move on from a BMI-centric approach to a complication-centric approach in obesity care. And the other obstacle in weight loss is maintaining it. Because as you can see, with most of the dietary interventions, people tend to lose weight, but in no time, they will regain their weight, as I described in the first case. So that is why I went into great depth of explaining all this physiological regulation of energy balance, because in summary, the moment you start dieting, your hormones change in such a way that your appetite stimulating hormone levels will go up and your appetite suppressing hormone levels will go down, resulting hunger and reduced energy expenditure, which will make our body to conserve energy and gain weight. And this is where other interventions like weight loss medications and surgery come into practice. There's an array of drugs for weight loss, starting from orlistat to the new kid on block, which is tirzepatide. But the fact that I want to highlight is these newer molecules gives a higher degree of weight loss in comparison and more or less in par with surgery for tirzepatide, and helps us in maintaining the achieved weight loss. And finally, metabolic and bariatric surgery is the most efficacious option we have for obesity care now, which of course gives a long-term and durable weight loss, which is superior to more than other methods that I've described. It improves the mortality, and most importantly, metabesity is addressed where diabetes, hypertension, dyslipidemia, and NAFLD all go into reversal. Does this apply to our population? Of course, there's loads of data demonstrating that they will achieve a significant weight loss. 88% had improvement of NAFLD in our cohort, 58.7% went into diabetes remission, 85.7% became normotensive, and there was a significant improvement in lipid parameters. So seems like a cost-effective option. And also, when we are discussing about the obesogenic environments, modulating this environment can help in prevention of weight gain, obesity, and preventing weight regain. So moving back to our initial case, where did we go wrong? She had a family history of obesity. She was overweight as a child. She was obese as an adult, and she had a history of gestational diabetes. So clearly, 3 generations are affected here. And had we planned our interventions very early in this disease, we should have prevented all these downstream complications. So in summary, metabesity is a spectrum of interconnected diseases which share a common metabolic and inflammatory roots, and it's a growing health and economic problem worldwide. Obesity is a key driving force whose pathophysiology is complex and multifactorial. Therefore, interventions should start early. So with that, I would like to conclude my presentation, and thank you very much, Ceylon College of Physicians, for the opportunity given. And I would like to thank my trainers, Dr. Udita Guluhapatia, Dr. Manika Sumatilaka, Dr. Sivadasha Padmanathan, as well as my previous trainers, Dr. Harshini Fernando and Dr. Ganesh Alina, who is present here. Thank you.
Thank you, Dr. Vijayanaka. Any questions you like to ask?
Dr. Vijayanaka, thank you very much for the interesting lecture. Now, in your clinic, do you see a lot of obesity patients, and if they are treatment for these obesity patients?
Yes, sir. Yes, sir.
And do you use the new drugs, and how's the experience with the new drugs?
Yes, sir. Because at our clinic, we are offering metabolic and bariatric surgery also as an option for obesity patients. So we see a lot of patients. And for assessment of obesity, of course, we still use body mass index and other measures like components. But planning metabolic surgery, we are offering visceral adiposity assessment in the form of whole body index. And moving on to pharmacological treatment, in fact, we still have the option of we are still using that as an agent, which of course is once again not available in the government sector. So if the patient can afford it, they can use it. But the degree of weight loss which is achieved through orlistat is not that satisfactory, and there's lots of side effects with that drug. And of course, we are offering metabolic and bariatric surgery for the patients in which it is indicated.
What do you mean by body fat percentage?
There are 2 aspects. One would be the total body fat percentage, which of course assesses the visceral as well as subcutaneous fat. And the other assessment would be visceral adiposity, where by techniques like whole body DEXA and MRI, you assess the visceral adiposity. But in the clinic, of course, we have there's apparatus to assess total body fat percentage, which will give some sort of idea about the fat.
Yeah, just for the virtual audience, I think the questions may not be heard. The first question was what Dr. Kulsanaka want to know is what what is available in clinic setup in government hospital for the obesity patients to come in, and the use of pharmacological measures is available. That's what Dr. Vijayanaka answered for. Second question was on what is body fat index. Yes. Okay, so she answered both questions. Any other questions?
Can I ask something?
Yes, Dr. Arunathan, go ahead.
Yeah. Thank you for that excellent presentation. Can you hear me?
Yes.
Yeah, we can hear you.
Yeah, okay. Compared to the medical and the other therapies and the bariatric surgery, is it you first try the other ways, other forms of therapy, and then go for bariatric when it fails? Or are there indications of bariatric if the level of metabesity is high, you will go straight for bariatric surgery without waiting?
Yes, sir. According to the Endocrine Society recommendations, still, as I mentioned, the guidelines give us the treatment guidance according to the BMI category. So if the patients are in class 3 obesity, and for that Asians, we use the Asian specific cutoff values. If they're already in class 3 obesity, then of course, metabolic and bariatric surgery would be the treatment option. Whereas patients who are in much lower categories, we can try with pharmacotherapeutic agents, but the recommendation is if they have, like if we have used pharmacotherapy for 3 months and if it has not caused a weight loss more than 5%, then we have to move on to decide on whether we are offering metabolic and bariatric surgery. And on the other hand, there are newer scales coming up like Edmonton Obesity Scale, which of course addresses all these factors, obesity as well as metabolic complications, in determining the treatment options for these patients. But still the guideline recommendation is that.
Thank you. Thank you.
Any other questions? Okay, in absence of any other questions, thank you very much, Dr. Umesha Vijayanayaka. I would like to hand over the certificate of appreciation for this part of your presentation.